O pessoal está chegando aí. Muito obrigado aí pela presença de todos. Quiserem abrir a câmera, os palestrantes aqui, o pessoal que eu convidei, fiquem à vontade. Olá, Elaine.
Boa noite a todos, tudo bem? Hi, Sam. Where are you?
Hey guys, here I am.
Olá, Daniela, tá por aí?
Hi, I'm here. I can't.
Oh, let me see.
Let me do it. Yes, that's it.
Ok.
Good night.
Olá, vamos. Just a second, Sam. Just a second. A little bit of Portuguese is good to practice, ok?
Sure.
Muito obrigado a todos pela presença. É um enorme prazer, a gente está fazendo um evento aqui, é um bate-papo, e assim, um bate-papo descontraído. Tanto a gente trabalha em ver webinar, né? Tanto científico, tanto estudo tal. Aqui hoje é um dia para ser algo mais descontraído, vamos pegar a visão um pouquinho do Sam Dyer, que é eu considero uma das grandes celebridades aí no mundo dos alinhadores. Tive a oportunidade o ano passado, de fazer uma entrevista com o Sam na Dental Press, e a Daniela, editora da Dental Press, me ajudou aí nesse afazer aí, agradeço muito a ela, e não tinha como não convidar ela para bater um papo aqui com o Sam junto conosco, né, Dani? Obrigado por ter aceito o convite, estar aqui conosco. E temos aqui a Elaine. Elaine, a Daniela, você é professora da Universidade de Vila Velha, lá em Vitória.
Isso.
E eu sei que você tem bastante, você fez o ERJ, né? Se eu não me engano. Eu sempre vejo você com o pessoal da...
mestrado e doutorado. Eu sou uma filha que voltou a casa e várias
lá,
vezes.
né? Simpatizo muito com o pessoal lá, muito legal a turma. E aqui, sempre me acompanhando, faço questão de convidar, ela não sabe, mas Maurício, o que eu vou fazer? Não sei, você vai lá, dá um sorriso, para mim já estou satisfeito. Elaine, muito obrigada por estar aqui com a gente.
Vocês estão rindo, mas é verdade. Eu falei, o que eu vou falar com o Sam? O que você quer? Como vai ser? Vai lá, vamos conversar. Ok, let's talk to Sam a little bit about orthodontics.
Pessoal, agora eu vou mudar para inglês. Quem quiser ouvir em português, tem a opção aqui, interpretação, mudar a língua para português. A gente vai ter tradução, ok? Então, let's switch for English and talk with Sam Dyer. Sam, thank you very much for accepting our invitation to talk a little bit about your experience, about you. And well, I invite you many times to come to Brazil, and you accept all the time. Thank you very much for your consideration for us. And it's a really pleasure. Sam Dyer, for me, it's a reference for aligners. I remember the first time that I saw you, I don't remember each year, 2010, 2011, in that summit in Las Vegas. And Sam Dyer was something that make me noise a little bit, because it's something that shocked me a little bit. Not shock me, but get good reference of orthodontic, because every time use as a reference orthodontics, the traditional orthodontics, use a reference. This is, I think, is a gap that a lot of people forget about. It's forget about orthodontics. Orthodontics is essential. It's a base for everything. Everything starts in the correct and good diagnosis. And you need to know everything about orthodontics to get a good diagnosis. And Sam Dyer do it very well done. Very good, very bad. Well, before Sam starts talk, let me share with you guys some, a little bit. I will share some slides, talk about. Okay. The first time that Sam Dyer came to Brazil was in 2014. We did an international forum, and I invited 80 doctors, and Sam Dyer was one of the guys there. So we had more than 400 doctors, and a lot of people really start to use it as a reference Invisalign after that specific event. And well, after that, Sandai was invited to reading to come to Brazil many times. Well, let's see, this was very good event, a lot of friends, and Sandai was here, talk with everyone, and so their cases was very nice. And 1 year later, and he was invited to go to Florianopolis in Abor, and it was a pleasure. And he said, "Son, please, Florianopolis is a very nice place. You should bring your family." And he was, he liked the idea. Invited his wife, his lovely wife, and his small daughter, Yasmin. And I also said, "Son, come here." One day before I arrive, 1 day before Son arrive, I send a photo to Son. "Son, come here. It'll be very nice in Costão do Santinho. It's very nice to see the weather." Well, at the time Son arrived there, it started raining and raining for all weekend. Son couldn't see the beach, we couldn't go even get good pictures because the weather was terrible. Well, so I have to invite Son next time to to come to Florianopolis. Well, in November 2016, Sandair came to Brazil, and Sandair and Ritesh, Manuel Roman, and me, we did a road show, São Paulo, Rio de Janeiro, Porto Alegre, Belo Horizonte. Talk about the Invisalign new phase in Brazil. So I don't have photos I didn't find the photos. As I know that I have, but I haven't found the photos. And in February 18, Sandair, John Martel came to Brazil to an event in Align Technology, and in Congress in Curitiba, June 18, he came to Brazil again, he went to Curitiba, and was a nice event. In 2019, he didn't come to Brazil, but the Brazilians came to New York to meet him. We did the event, a master class event in the University of New York. It was very nice. And 2020, everybody know that we had a COVID. Nobody could come. Nobody could go there. So we haven't 20. We skip 20. We have this. We did this. I mean, you cannot see the image, but you have the Dental Press magazine interview. So every year we have something to show you. Well, before we start the questions and ask it, I'd like to talk about San have a experience, a huge experience with aligners, and also he started a service, started working with service of treatment planning besides your office and everything. Tell me a little bit about this, San, and well, and then we're gonna skip this and gonna stop the presentation. We can talk.
Well, listen, first of all, thank you for having me. It's I think all your listeners know that I have a special soft spot in my heart for Brazil and for Brazilian people. I travel the world. I've been all over the world, and Brazilian people always have a soft spot in my heart. So thank you. I always say yes to Brazil, and hopefully when the coronavirus is over, I'll go back again. Because I love the people and I love the food, and I love the beaches, so everything is great. And you're okay too, Mauricio. Eleni is absolutely beautiful inside and out, and I love to see those beautiful kids of yours as well. So in any event, thank you for having me again. It's my honor and my pleasure to join you. The reason I started the treatment planning service, the DAR Institute, is because I give so many lectures. The other time we're trying to count, I speak to about 400,000 doctors worldwide. So a lot of the doctors will come in and say, "I like the way you think. I like the logic. Can you help me with my clin check?" And I'm always on the road. So finally, I decided a few years ago to do my treatment planning service so that my doctors can get a glimpse into my thinking as to when I modify a clin check, what's the thinking behind it. So that's what I do. I elaborate a little bit and I explain this. And the funny thing is it's in English, but many of my doctors are actually I have some from Brazil. I have some from China. I have some from Australia. So it's all over the world, Canada and the US, of course, as well. And I have a lot from France because French is my first language, of course, as well. So it's nice. It's a way for me to keep in touch and communicate with my colleagues. And it's something that I really enjoy. Unfortunately, it sort of happens after hours and on weekend, but it's something that I enjoy. So just reviewing the ClinCheck, I've been doing Invisalign for so long that now when I see a patient that has braces on, I have to close my eyes and imagine a ClinCheck in my head. So when I first started 19 years ago, I used to close my eyes and see braces. And that's how I treat the case. Well, now for the last 10 years, I close my eyes if it's a braces case and I think of a ClinCheck. That's how I see it. So it's become an extension of my fingers. And so when I modify a ClinCheck, I've treated so many cases and I've made so many mistakes. I don't want to get to the idea that I don't make mistakes. We learn a lot from our mistakes. But I made so many mistakes that as soon as I look at the ClinCheck, within 30 seconds, I would know what's going to work and what's not going to work and how I should modify it. What actually takes me time is explaining it to my colleagues. That's what takes time. But in terms of looking at it, the first glance, I can tell you what is not going to go well or what's going to go well. But then I have to think about explaining it to my colleagues and to my peers. So that's why I started this treatment planning service. I enjoy it. It helps me keep in touch with my colleagues and I make a difference. And I enjoy that quite a bit.
And Sanu, how you manage, how many days you stay in the office and how many time you deliver for the treatment planning service?
So, and that's a good question. So I used to have actually 6 practices across 3 provinces. And those of you that know, Canada is the second biggest country in the world, right? So, so I had provinces in 3 different, I have sort of practices in 3 different provinces. So I sold them all and I kept one right now. So I only work out of 1 practice and I work 2 to 3 days a week. And the rest of the time, I usually Thursday, Friday, and Saturday, I lecture for Invisalign. I'm a key opinion leader. I'm a consultant. So seeing patients is limited to 2 days a week. The other 5 days is working on the treatment plan service or lecturing or consulting for Align Technology on the new ideas. I usually test their new ideas as well and their new concepts.
Excellent, excellent. Elaine, Daniela, feel free to ask, to talk, enjoy. I don't know if Elaine has some clinical questions or Daniela, whatever, feel free to. Sun is able to answer anything you want, correct?
Correct.
Yes. That's great. I have many questions.
Oh, great.
Nice to meet you. It's really an honor to be here with you. And I'd like to know, you said you commit many mistakes before.
Yes.
And do you have now a routine to study your ClinChecks and make an analysis of what worked and what did not work? How do you continue this education, these studies? How do you do this?
So Daniela, and this is an excellent question. I love systems. Everything I do is a system. Now, what you want to keep in mind with Invisalign is by the time you finish the case, it's going to be a year to a year and a half, right? So by the time you learn your mistake, it's going to be a year and a half. So you start making the changes for the next cases. But I have a system. For instance, deep bite. I like to treat them. I like to start off with a certain way. I like to do a little bit of expansion. I like to level the curve of Wilson and the curve of Spee. I don't like to intrude the canine. So I have my preferences that I usually implement per malocclusion. So I go per malocclusion, deep bite, class 2, class 3. I have a way of treating them, but then once I submit it and it comes back, and then I make it specific for that one patient, right? So for instance, open bite and deep bite, I usually like to open bite, for instance, I like to close intrude the posterior teeth and then close the mandible. So I do that routinely. But then when the ClinCheck comes back, then I make it specific for that one patient. So that initial system usually takes care of 80% of my instructions. So each malocclusion, I have its own system and then I modify it. And as I make more mistakes or as I learn what new things work better, I keep tweaking my preferences a little bit at a time. So early on, it was a lot of modifications. Right now, for instance, with the G8, for instance, with the new release of the G8 from Invisalign, that helps with the cross-bite correction and the deep bite quite a bit. So I don't need to tweak it as much anymore, but I have my own preferences. I like to change them, but each malocclusion has its own. Now, how do I look at it? I go through it systemically. So when I open a ClinCheck, the first thing I do is I look at the initial malocclusion and I look at the final solution, at the final occlusion, before I even go through the step-by-step. I want to make sure that I got what I asked for. I have my own technician with Invisalign, and I'm lucky and I'm happy about that. But every now and then, she may not understand what I'm trying to say. That doesn't happen often, but the odd time that it happens, I want to make sure, for instance, if it's a surgical case, for instance, and I'm doing mandibular advancement by surgery, I don't want her to distalize the upper teeth because I'm doing surgery. So if she misunderstood, I want to go directly to the end. And if I find she made a mistake, I'll go back and say, hi, please modify it as such. So the first thing I look is the end result. I look at it from the anterior, from the left, from the right, from the upper occlusal, and from the lower occlusal. Then I turn it around and I look at it from the back as well. I do that routinely with every single ClinCheck. And then if it is what I like, then I go through them step by step. I go through the ClinCheck and I play stage by stage, see what kind of movement we're getting. How's that going to affect the gingiva? How much IPR am I doing? Is that realistic or not? If it's not realistic, I'll modify it, but it's always the same thing. Look at the end result, look at it from the center, right, left, upper occlusal, lower occlusal, turn around and look at it from the lingual view from the back. I do that with every single case. So it becomes robotic almost at this point.
And when you finish the case, you take pictures and make some comparison with the ClinCheck?
Yes, so I do that. So when I first started, that's a good question, Danielle. When I first started Invisalign and I was still learning, so right now I buy cameras at every chair. So for instance, my Vancouver office, I had 6 chairs. I have 6 cameras. So I take pictures at every single visit, but it takes 60 seconds. So the assistant will take pictures at every visit and I compare them. So if the case is going well, unfortunately, when the case is going well, we don't look at pictures a lot. It's when the case is not going well, we tend to look at pictures more. And then I go back and analyze. I figure, where did it go wrong? I usually do that at the end of the day. I'm going to tell you a secret. So my practice is downtown Vancouver and I live 30 minutes away. If I get stuck in traffic, if I leave at 5 o'clock, I get stuck in traffic. So I actually stay for 45 minutes in the office to beat the traffic. And that's when I go through my ClinCheck and I compare and I look at where did it go wrong at what stage and what is it that I did wrong. And I keep a mental note. And that, so if I made a mistake, I'll actually leave myself a note. I have a Word document on my computer whereby I leave myself notes. I say, for instance, when you're doing rotation, please make sure you have interproximal space available. So now when I do the ClinCheck, I remember to keep space open the space before correcting the rotation or before doing intrusion. So I actually leave these notes for myself on a Word document that I leave on my computer desk. So yes, I look at the pictures. If it's going well, again, unfortunately, we don't look at them. It's nice to have, but if things are not going well, that's when we look more at pictures and see what we can do to improve.
Is following the question of Daniela, how about the progress assessment of iTero? Do you use it to compare with results?
Yes, so and this is great because it actually superimposes it quite a bit for you. I rarely do it. I still do it, but I rarely do it because I just jump into the latest iTero about 6-7 months ago, right in the middle of COVID, where you can I started using it more often. On the days that I'm not there, I'll ask my associates to scan and check it for me. But usually, if the aligner is fitting well, then that's usually a good indication for me. But do I use it? I'll tell you, maybe 5% of the time when I do the iTero superimposition. It does help when things are really not going well. It helps quite a bit.
Yes, that's nice. And I have a clinical doubt. I have a lot of difficulty to correct deviations of the midline.
Yes.
With aligners, even if I perform IPR, sorry.
Yeah.
And usually I'm using crossing elastics to
Yes.
correct it. And it's the only way I find to correct.
Yeah.
How do you do this? How do you have success with midline correction?
So Daniela, I actually have better success with aligners when I correct the midline than I do with braces. The reason for that is, yes, I do IPR. IPR is one of the main things that will help me correct the midline. The other thing that I do, and what I do is, you'll notice most of the patients that have especially a maxillary and upper midline deviation, you'll notice that the shape of the arch is usually well-rounded on one side and flat on the other. Almost 9 out of 10 cases are like that. So what I do is I cheat, well, actually not cheat. I go back and reestablish symmetry. More often than not, what I do is I go back and recreate the corner. So I skew the arch a little bit. And you can do that with aligners better than you can do that with a stainless steel wire, for instance. So yes, I do IPR, but I always skew the arch a little bit. So if it's flat on one side and it's well-rounded on the other, I'll make it either well-rounded here or flat on the other. So long as they're right and left symmetry, 2, maybe 3 millimeters, that works well. Now, if you get into 4 or 5 millimeter midline discrepancy, that's usually either a Bolton discrepancy or there's a missing tooth. So that's usually a bigger problem. So if I find that it's 5 millimeter, for instance, I actually go back and create space for an implant on the side where I need to shift the midline. I've done that on one case whereby a patient was not missing a tooth. It was just an asymmetry. The whole arch was asymmetric, and the patient didn't want surgery because surgery would be the ideal. So what I did is I actually created a space for a third premolar, right? And the best way to do it, and that helped me shift the midline and create 7 millimeter of space. So that's one creative way of doing it. So shifting the midline is a challenge, but I find you can control the arch form with aligners better than you can with stainless steel wires or nickel titanium wires. So yes, IPR, but that's not the only thing. Recreate the shape, and whatever you do on the upper arch, you have to mirror, you have to do the same thing on the lower arch as well. And with a combination of these, as a matter of fact, there's a case that I'm presenting at the AAO whereby the midline was shifted 3.5 millimeter, and the case ended up looking good just by changing the shape of the arch.
Great. Thank you. Thank you very much.
You're welcome.
Sam,
Yes.
and do you use to build overcorrections in your setups?
So overcorrection, I build it for rotations. Any other movement, I know some of my colleagues, when they treating a deep bite and they're intruding the anterior teeth, they open, they overcorrect. I don't like to do that. The only time I like to overcorrect is the rotation. Because what happens is, I've been burnt in the past whereby deep bite and open bite, you overcorrect them and they actually occur, they actually happen. And you end up going to have to go back and reverse. Whereas with overcorrecting rotation, all you have to do is let it relapse a little bit and then it will go back, right? Because you're stretching the periodontal ligament. So it is going to relapse, excuse me, a little bit. Whereas with everything else, I find that if I finish the case and I need to do a little bit more, I'd rather order additional aligners or do refinement and deal with it this way. But I'm one of those people, there's not a lot of people like me that don't like to overcorrect. I really don't like to overcorrect. Rotation is the only thing I overcorrect.
Good.
Yeah.
And do you work in your clean checks, you review alone, or do you have someone to help you?
No,
in
so
your own clean checks?
So my own clean check for my patients, I do it alone. So now, because I have my associates, the other orthodontists, because I need to teach them, I need to share my experience. So what I do now, what I've been doing lately, Lainey, is I let them do the initial clean check. I let them do the submission and do 1 or 2 modifications. And then when they're done, we have a little system. They send me a note, and then I go back and review it. If I like it, I'll tell them that it's good. I don't need to modify it. If I don't like it, or I think something's not going to work out well, I'll modify it. But as I explain it to the technician, I know that my associate is going to read my notes and they'll understand why I'm making the modification. So for my cases, I'm always the last person to review it. But now that I have all these nice associate orthodontists, I want them to learn. So I want them to do the initial step for sure.
Good, thank you.
And Sam, you're not working exclusively with Invisalign lately. You use other kind of aligners. Is it correct?
Well, not anymore. Yes, I tried ClearCorrect actually in 2019. I actually tried it for a full year. So I still have my patients Invisalign. I kept submitting cases with Invisalign, but I wanted to see what else is out there. Now, we all know that Invisalign is the better product for a lot of reasons, but I wanted to see it for myself. So I actually tried ClearCorrect. I did about 60, 70 cases in the span of a year. And it's nice to see how the company is trying to catch up and try to be on top of things. It really is nice to see. But their research and development, they're 10, 15, 20 years behind. So you have to appreciate that. So, but it gave me an idea as to what's available out there and how it compares. So I'm glad I did it. But in terms of difficult cases and in terms of what I treat with right now, I went back to using only Invisalign at this point.
Yes, I would like to know if it's of similar quality, and you just answered me that it's not. Okay.
Yeah, it's not. I'm hoping it will get there soon, but as of now, yeah, I mean, they're trying really hard, but I have to be honest with my colleagues on this call. It's not nearly as sophisticated as we're Invisalign in, by quite a bit, actually.
San, how about braces? Are you still? Do you know what braces means?
Yeah, it's those metal things.
How about braces? Do you have some patients with braces or?
Yes. So here's what it is. So in my practices, as I have my associates that work for me, I can't tell them not to. They all know I'm the Invisalign king, so they want to do Invisalign. But there are times where they still want to do braces. It's not, I can't tell them not to. So they still do braces. And when I go to replace them, if they're on vacation or if I'm doing emergency, I still see we use self-ligating braces. So we still see them. It feels a little bit strange for me, I have to tell you, but I haven't forgotten. You mentioned early on, Mauricio, how I still think in terms of biomechanics. So whether it's plastic or aligners, my thinking is the same. I still think of the biomechanic. What are the secondary effect? How is that going to affect the teeth adjacent to it? So yes, I still see braces patients. I never start a braces case, but my associates do, and I don't want to discourage them either. I want them to be comfortable doing what they do.
Sam, we have a question here in the chat from Dr. Fabiola. Yeah. How much jump do you accept in the clean check? How much is real to active using elastics? Is her doubt.
It's like elastics. Do you mean for like class 2 and class 3 or for extrusion?
Yeah, I think it's mean class 2, class 3. About the jump, the anteposterior jump.
Yeah.
The surgical corrections.
So with the elastics, because I was one of the doctors that tested the mandibular advancement, the MA feature. I was one of the original doctors that tested it back 3, maybe 4 years ago. So I got good results, but that applies to growing patients. So how much of an elastic jump would I accept? The first thing I look at is the age. If it's a patient of 18 or maybe 17 or younger, I would accept 2-3 millimeter elastic jump. If it's a patient older than that, maybe I'll take 1 millimeter. If it's a patient that in their 30s, 40s, 50s, I probably won't accept any elastic jump, quite frankly. So what I want to do is, it doesn't mean I'm not going to get it. I still want to distalize the upper teeth. I still want to use class 2 elastics. So if I get that additional elastic jump on an adult, I'm happy. Nobody's going to go from a class 2 to a class 3. You know, we're all orthodontists here. We know it's not going to happen, right? But if we do get that extra millimeter, then I'm happy. I don't want to count on it. So the answer is, I look at the age. And if it's anyone 17 or younger, I'm willing to accept 2-3 millimeter jump. If they're 11, 12, maybe I'll do even 4 millimeter jump sometimes. So long as you start with the elastics as early as possible, like aligner 3 or 4. In that case. But there are times where I do, let's say a 25-year-old, you may still get maybe a millimeter of an elastic jump, but I don't incorporate it. I'll ask my technician not to incorporate it. I will sequentially distalize 1 tooth at a time. And if I get the elastic jump, then that's an added bonus at that point.
Sam, with the same question. Yeah, I know that you belong you was part of the group of the started the mandibular advanced feature,
Yes.
and at the time you made patients with 11, 12 years old using class 2 elastics. How do you like the feature? How do you prefer class 2 elastics or mandibular advanced feature?
So actually, when I first started the mandibular advancement feature, I was very cynical. I wasn't sure it's going to work, but I figured we have to try it. We have to test it. And just so you know, the form that you guys see right now, we started actually three different forms. The form that we settled on, the buccal wings right now, were the ones that work best, because we also tried the occlusal wings. We tried those and those didn't work very well. So I was very cynical, but the results that I noticed were actually amazing. So given an option, if I have someone who's at early teens, 12, 13, 14, I would rather use the mandibular advancement, get as much as I can. But I'm one of those people, once I get to a class 1, or even if I'm a little bit short of a class 2, I still use class 2 elastics, but without the mandibular advancement. In other words, I want to get the mandibular advancement feature, get as close I can to a class 1, or even if I get it to a class 1, then I switch to regular Invisalign. I still use class 2 elastics to either maintain it or give me a little bigger jump. So whenever given an option, I do the mandibular advancement first, and almost always finish with class 2 elastics as I'm doing the regular Invisalign.
Okay, thanks.
Good. We have another question in the chat. The doctor is asking about, I don't know if you have the first and comprehensive in
Invisalign
Canada.
first, yes.
Yes, the same.
Yeah.
And
Oh, she froze on me.
start with comprehensive.
I missed some of your questions, Eleni, because your feed froze a little bit. The computer.
Yeah, I will ask again.
Please.
The doctor is asking about your experience with Invisalign first.
Yeah.
Or if you prefer to start the case using comprehensive. When you use first or comprehensive?
So with Invisalign first, and I've used it, and I was happy trying it. So I like to use Invisalign. If you have to think of a 7, 8-year-old, they're still in the mixed dentition. They still have primary teeth, or milk teeth, like they call them. I don't want to go into full Invisalign, because am I going to keep him in Invisalign for 6, 7, 8 years? I'm not going to do that. So I would rather use Invisalign first. Now, what's nice about Invisalign first at this age, you can still get dental. You're not going to get skeletal expansion, but you still get dental expansion, and you get it quite nicely. You can use it as almost as a band and loop space maintainer almost as well. So you can get a lot done with Invisalign first. And I was again worried about some of these kids not wearing the appliance, but they're a lot easier than a band and loop. There's a lot easier than a removable expander and all that. So the kids tolerate them a lot better. Because they tolerate them a lot better, they end up wearing them a lot better. Now, I don't expect miracles from these. I don't want to, if for instance, a patient lost a baby molar and the upper molar sort of tipped mesially, I'm comfortable using Invisalign first to tip it back. And that actually works quite nicely. And you're holding the space until the premolars come in. So cases like that, I love using it, because if you use a distal jet or something like that, you have to keep activating it. Whereas with Invisalign first, you switch the aligner every week, maybe every 10 days if you have to. So for cases like that, they work well. Now, if you need skeletal expansion, that's a different case, of course. If you need a face mask, it's a class 3 patient. That's all skeletal problems. But Invisalign first, again, I was pleasantly surprised to see that the patients were willing to accept it. They wear it. And because it's gradual and they switch once a week, it's way better than using an appliance that you have to activate and bring the patient back in every now and then. So it has worked well for me.
I had some opportunity to talk with doctors and see their setups, and Sometimes I see people trying to do Invisalign first try to get a complete treatment of that. Invisalign first is a product for phase 1 treatment. So the focus is back in the diagnosis, phase 1 treatment, and this is the product can help some situations, and that's it. Yeah.
Well, Invisalign first is not meant to be a comprehensive. It's what we call phase 1 treatment, right? So it's supposed to help get the patient ready for the comprehensive. That's how you have to think of it. It's an appliance that you need to use to make your life and your patient's life easier when you go into full comprehensive treatment. It's okay if you fall short of some of them. For instance, again, if that 6, the molar, for instance, is leaning mesially and you're trying to upright it and you upright as much as you can, and you end up, for instance, with 7 millimeter of space for the premolar instead of 8, well, that's still, to me, good enough. So when you go into comprehensive, then, it's a stronger plastic, they have more teeth. Then at that point, you can go into full comprehensive, but try to get it all done during the comprehensive. You're not doing yourself a service because you may end up burning the patient. You get patient burnout, plus you still end up needing to go with comprehensive. So do what you can with it. Use it as a space maintainer sometimes. And in order for me to last, sometimes I have the patient wear it 10 days instead of 7, simply because I want to get what I want as much as I can. And then if it makes my life easier before I go into the comprehensive, that's good enough. But at this age, keep in mind, those teeth move so beautifully well at the age of 7, 8, 9. Those aligners do an amazing job on these kids at this age.
It's true. We have another question here in the chat. Do you remember Leda from Florianopolis?
Yes.
She's here in the chat. And give you a hi.
Hi.
And,
Leda was a host, a guide for us to do a tourism in Florianopolis. She was very nice.
Did a good
it was
job.
very nice moment there.
Well, I'm glad to know you're on. Thank you.
Dr. Soraya, that's been with us in New York too. Hi, Sam. How often do you change optimizer attachment for conventional? Thanks a lot. Good to see you.
Okay, well, thank you for the question. It's good to hear from you. Listen, so with the new attachments right now, with the optimized attachment, they've become so sophisticated that I used to change them a little bit. For the last couple of years, I don't change them anymore. Honestly, I don't change them anymore. The only time I still make an exception is on the canine. You know, when you get those tear-shaped, large attachment, they look like teardrop. Those are the ones I sometimes remove, and not because I don't like them, but because they're so big at the corner of the mouth, they're aesthetically are not appealing sometimes. Luckily, we don't use them a lot. But in terms of attachment, no matter how good I am at estimating, the software has an algorithm that factors in how much do you want to move the tooth, in what direction, how much force do you need. It's so sophisticated that it actually gets it right all the time. So I rarely, at this point, up until 2 years ago, I used to change them, but up till now, the only time I may remove them is if there's an aesthetic concern right at the upper right canine, especially on a beautiful, delicate female face sometimes. But other than that, I usually don't change them.
Sam, do you remove it or just substitute, put a rectangular?
Yeah, so I substituted with a smaller attachment. That's a good question. I don't remove it completely. I just remove it and request a smaller, maybe a rectangular attachment at that point.
And for rotation, do you use a vertical or horizontal?
So for rotation, vertical.
Vertical.
Yeah, for intrusion, extrusion, I use horizontal.
Thank you.
Yeah, and if it's both, I would rather the vertical. I trust the vertical more.
Yeah. And how about the laterals, incisors? Do you like the optimizer attachments?
Yes, I like those optimized attachments. The one thing that I've been doing though, and I spoke at the summit about this, is sometimes I add, I have to tell you, I don't like lingual attachments. I don't use lingual. I tried them before because Dr. Willie Diane convinced me to try them 12, 15 years ago. And it was a disaster. I really don't like them. But the one exception I make is for upper laterals. I place them on the inside, on top of the attachment that the software places on the buccal. So I still place a lingual attachment, and I find that that helps me just because that tooth is so small that if you can get another purchase point on the lingual surface, then that ends up working well. If I also talked about that on the summit, if you find that the tooth is weird in shape, I sometimes add a bit of composite resin on the lingual surface and I create a bit of an undercut. It's not really an attachment, but an undercut, and I build it and then I scan the tooth. So it looks like whatever composite resin I added in there is actually part of the tooth. And then this way we add the buccal attachment. So I do one or two ways, but more often than not, I just request a small lingual attachment. And it doesn't matter whether it's horizontal or vertical, it's usually horizontal, so long as you get another purchase point from the lingual, and that usually helps. One thing I want to mention is the patients, when they bite down, they will feel it. You have to warn them. It's not a mistake. We put the attachment there on purpose. You will feel it. That's okay, but it is helping because sometimes patients leave and they come back the next day or they call, they say, my tooth is touching. Was that a mistake? So now we tell them before they leave that it's not a mistake. It's something we added in there on purpose. As a matter of fact, it will force them to wear the aligner because when they wear the aligner, it becomes more comfortable.
Good. Right. And how about your changing aligners in how much days?
So
Good,
and that's a good question. Anywhere between 7 to 10 days. I don't do 2 weeks anymore. More often than not, I'll do 7 days. If I find that things are lagging behind a little bit, maybe I'll do 10 days, but usually 7 days. The one time I may still sometimes do 10 days is early on when I'm doing distalization. I find when I distalize the second molar and then the first molar, those you sort of want to take your time. So maybe for the first 10 aligners, when I'm doing distalization, I sometimes do 10 days, but then I switch back to 1 week after that. If a patient is not wearing the aligner, you can tell, right? Some of these patients just are not good at wearing the aligner 20 hours a day. Those patients, I may ask them to wear it for 10 days each, but I can't recall doing 2 weeks anymore. It's 90% of the time it's 7 days, 10% of the time is 10 days.
Not always the patients. Sorry, Daniela. Sorry, Daniela. Go there.
If you have a tracking problem, and for example,
Yes.
the patient didn't use it, you have a tracking problem, you can't use for more days, for 15 days, for example.
So I find, and so I found out from John Morton at Invisalign that the aligner after 10 days loses its elasticity. It becomes a retainer after 10 days. And that's why wearing it longer than 10 days, I don't find it helps anymore. Okay. So the odd time, I'm not yet telling you to do this, but the odd time, let's say the patient wear the aligner 10 days, you haven't bite on the chewies and the tooth is moving well, but you still want more time. I actually order a new aligner, the same number, but now you get a fresh aligner. It's a lot more flexible. I don't do it a lot, but sometimes I actually do that. This way they end up wearing the same aligner for 20 days, but it's fresh. It stays fresh because it's 10 days, then it's 10 days after that.
Great.
I think is a good point, Daniela. And one point is the compliance, patient compliance. Do you help with chewies? Do you use some different tool to that, like a V-Pro 5 or something like that, as a regular
as
treatment?
an adjunct? Yeah. So the V-Pro 5, those work because what they do is with the vibration. There's a lot of research that says the vibration will stimulate the biology. But the one thing that I know for sure, they actually almost use it like a chewy anyways. So it will make the patient more compliant, right? But if they don't want to buy the V-Pro, if they don't want to pay a couple of $100 for it, I make sure they use the chewy. The one thing that I've been doing lately is I've actually been buying chewing gum for dentures. Like those are the ones that don't stick to plastic, right? Because you can't use regular chewing gum. This is people that have dentures. There's a special, I forget the name, you guys, my staff buy them. So I sometimes give them a pack of gum, which is chewing gum for dentures. And I say, hey, if you don't want to use a chewy, use this at least for about 5 minutes a day. That has worked. Anything to help them bite or clench, using the chewies, the V-Pro 5, all of these are good because ultimately what they do is they help Once they seat the aligner will get activated, and that's how the teeth will end up moving. That's why after 10 days, when they lose the elasticity, they're not efficient anymore.
I'm gonna try to find a chewing gum for dentures here in Brazil. I don't know if I have it, but I'm gonna try to find, because it's a great idea.
Yeah. Well, try it. Listen, if sometimes compliance is, it's always compliance is our biggest issue, right? So if you get them to motivate them and you get them to do that, then that's good. Whatever works for them. Because there are times though, Daniela, I sit the patient down and you look them in the eye and you say, if this is not working, I'm going to give you your money and you go away, or you're going to let me put braces on. So that usually scares them into wearing the aligner 20 hours a day.
Great.
My patient likes to bite the finger.
The finger, yeah, I know some patients actually do. They bite on the finger as well, but man, it's I don't want to encourage
it's easier to find, Daniela, a finger.
Yeah. No, I know it sounds silly, but some patients do. I would rather they not. It's just because it's chewy and soft, but I would rather for sure, because they won't bite as much as you want them to. But a cotton roll would usually, well, I know, I mean, I have, when we run out of cotton roll, we take saliva ejector, like the saliva tip, and we cut them. Sometimes we can use that if we run out of those, but usually chewies are available, or chewing gum for dentures would work well.
Sam, another question from the chat. Dr. Luciana Westing. Hi, Sam. What do you think about distalization with Invisalign first when you have the second molars? She's talking about the upper one.
Yeah. So I find when there is, so you get two things. The one thing is when they're young, distalization works well. The bad thing is when the second molar is in, it becomes a little bit more challenging. However, if the 7 is completely in, it's easier because you can start with the 7. If the 7 is only halfway in, that's when it becomes a little bit more challenging, right? But I still would try it. I personally, I'm one of those believers that unless you try, you never know if it's going to work. So I would still try it. If it doesn't work, then I'll wait for the 7 to come down completely, and then I'll do it with comprehensive. I'll distalize before the 8 come in. At the age of 12, 13, it's beautiful to distalize those second molars. I will still try.
And I think it's a good moment to add the comprehensive, not Invisalign first, because you can see this patient till 17 or 16 years old. So
yeah. And at this age, yeah, you can, because whatever Invisalign, I think they still give you 5 years before you run out of options. So you might as well go straight into comprehensive at this stage.
And to distalize the second molars, do you have success using TEDs? It's the question from Daniela.
So, yeah. So the question with distalization of the second molar, I sometimes use TAD, especially for the lower. In the upper, if it depends on so the age of the patient plays a big role in my treatment plan, right? So if I get a patient who's, let's say, 14 years old, and the third molar, the wisdom teeth have not come in and they're not in the way, then I distalize the 7 and it works beautifully well. If I have a 19-year-old, for instance, and the third molar is right there, I will extract it and distalize the 7, and that still works well. Actually, when you extract the wisdom tooth at any age, the 7 will distalize so fast and so well. I actually like to see the third molar in place. I like to see the wisdom teeth. And then I go to the patient, okay, I'm going to get you the aligners ready. But just before you start the first aligner, you have to extract your wisdom teeth. And a week later, I start with the distalization, and that works beautifully well. The lower arch is a little bit difficult. So when I use mini screws or TADs, it's usually for the lower arch, not for the upper arch.
Good.
Sana, I have a question. How about is your retainer protocol? I mean, do you use Vivera? Do you use lingual bar in the lower arch? How is the most of cases?
So most of my cases were retainers. I use the Vivera because if you look at most of our cases, no matter what the malocclusion is, we always do a little bit of expansion in the upper arch. And we all know that most of our adult patients, because the elasticity of the cheek decreases with age, they end up causing constriction of the maxillary arch, right? Because we lose elasticity. Not young people like me, old people like like my parents, right? I'm young,
like me,
like
me.
you.
Yeah.
So what happens is the elasticity of the cheeks decreases, and it ends up causing constriction. So you work very hard to do a bit of expansion and give him a nice smile. So I always use a Vivera on the upper arch, always. On the lower arch, I sometimes use a lingual arch, bonded lingual arch, but more often than not, I would rather use a Vivera. So even if I use a lingual bar, I still give a Vivera on top of it. In other words, I bond the wire and I do the Vivera on top. The reason for that is when the wire gets undone, they panic. They call you. They want to see you in the middle of the week. What if they live in a different city? What if they moved? So I don't want them to panic. I want them to say, you have the Vivera retainer. Yes, the wire is undone. Keep wearing your Vivera retainer. Either come and see us at some point in the next couple of weeks, or go see a dentist or an orthodontist in your city and they'll take care of it. So it's more of it's like wearing a belt and suspenders at the same time. It's just for safety measure, I like to give those Vivera retainers. That's the second reason I don't like the wire is sometimes when the wire gets undone and the patient doesn't notice, the teeth start moving. And when do they notice? 6 months later, when the teeth have moved so much that now you need to treat it. Whereas with a retainer, as soon as it breaks or as soon as they lose it, they're going to call you and they say, get me a new retainer. So there's a bit of psychology behind this one. And that's why whenever I can, I like to give them Vivera retainers. The last thing is, once a doctor places a wire, the patient is under the impression that the doctor is responsible for the wire because they place a wire. Whereas when you give them a retainer in their hand, they understand it's your responsibility. You lose a retainer, you have to call us and order a new one. And if you lose it and wait 6 months, well, it's on you. I'm happy to retreat you, but then maybe I'll need to charge you a small fee for my time because it's really your fault. Whereas when it's a wire, in their mind, psychologically, it's the doctor's fault. So I'm not fond of the wires, to tell you the truth. That's all.
That's a great way to think.
Yeah.
I like it.
So I didn't say it. So last thing is I do 3 to 6 months full time. And then after that, nighttime only.
3 to 6 months full time. It's
yeah. You say
don't you? I'm worried about. I never do that because I worry about the thickness of the aligner.
Yeah.
It's different Vivera than aligner.
Correct.
So I'm more about to get an open bite because the Vivera, if you use a full time,
it's too thick.
I'm trying to avoid it.
Yeah,
just to
and you know
avoid
what?
this kind of situation.
And that's a good point. And as a matter of fact, if it is an anterior open bite and you cause the intrusion of the posterior teeth to fix it with Invisalign, then upper lower Vivera is perfect for this patient. However, if it's a patient that clenches their teeth at night, they may actually cause opening of the posterior teeth. So you know what I do? I tell them to wear the Vivera. When you say full time, they end up wearing it 18 hours. They never wear it 22 hours. So I'll say wear them both all the time during the day. And at nighttime, you alternate. One night you wear the upper, the next time you wear the lower. So you alternate between the two. And I've done that in the past and that has worked well. But during the day, you wear them both. So even when you go into nighttime only, I still tell them to alternate because usually if you skip one night on one arch, it's not a big deal. So one night you wear the upper, the next night you wear the lower. And that actually has worked well for most of these patients.
And the last question from chat, Dr. Rafael Miranda. Hi, Dr. Sen. I would like to know that I got a case that the lower canine doesn't rotate. Should I do another IPR?
Okay, so it's hard for me to explain without seeing it, but this is a common problem with canines not rotating. So one of the things that you always want to do is you don't necessarily have to do IPR. What you need, when you write down notes to your technician, you want to say, please create a visual interproximal space, mesial and distal, to the canine. So the idea is they will move, you don't necessarily have to do IPR. They'll just move them out a little bit. It's going to be 2 or 3 extra aligners, but they will move it out of the way. Make sure there's an attachment. It doesn't matter what kind of attachment, so long as you have an attachment on the canine, but create space, then rotate it, then you close them. Now, don't ask for IPR, but go in with a polishing strip at every visit and loosen the contact, right? So don't ask necessarily for IPR, because the worst case that can happen, let's say at the end of the treatment, you still have a bit of space, you just order a couple of extra aligners and you close it with virtual C chains. So the idea is, don't ask for IPR, just ask for more space. But on top of that, make sure you go in and use a polishing strip just to polish in between the teeth at every single visit, and maybe give 3 to 4 aligners at a time rather than give 8 or 10, just so you can check it regularly in there.
Well, thank you, San. Thank you for your answer. And just to tell everyone here, for us, it's 8 p.m. And for some, it's 3 p.m. So it's the middle of the afternoon. I have to do this conversation. And so we are running short of time here. I have one question, and the point is, what do you see? What do you expect about the future of aligners in the world? I mean, what do you expect in 5 and 10 years? In what stage? What are you going to be orthodontics with or without aligner in your mind, in your perception?
Well, I think aligners are here to stay. I think they're only going to get better with time. And I think so you have to think, when I first started with this 17, 18, 19 years ago, everybody used to make fun of me. People used to laugh at me. How do you move teeth with plastic, right? But even back then, I knew that this is going to be the future one day. The idea behind it is, when all the doctors resist the evolution, it's not helping us. It's actually hurting us. But in reality, we all found out that you only need 20, 30, or 40 grams of force to move teeth. With stainless steel, with nickel titanium, sometimes we give 40, 50, 100, 200 grams of force. So what I'm trying to say is, yes, brackets and wires worked very well for 110 years, but you know what? We don't need that much force. A plastic can apply enough force to move the teeth. And it's also cleaner for the patient. It's more aesthetic. So the demand for it is there. So this technology is here to stay. So long as we all go in, and it doesn't happen right now. Invisalign is the king of the hill for sure. But I don't know what's going to be like in 10 years or in 20 years. No matter what company you use, make sure you voice your opinion. Make sure you tell them what is it that is not working and what is it that you like to see. Because that's how Invisalign grew. They started listening to the doctors, and that's how they actually started incorporating all these ideas. I was there, trust me. I heard it. I was part of this, all of this. So make sure you voice your opinion. Make sure you try different things. And it's okay at the end of the day. When I first started, I used to do Invisalign on everyone. And if Invisalign doesn't give me what I want, I do 6 months of braces at the end of the treatment. For me, that was my safety net. That's what made me feel good about it. Yes, it cost me a little bit more, but I provided a good service and it made me a better orthodontist. That's just thinking outside the box. So aligners are the future. I think they're going to incorporate a little bit more. I can see it one day using the intraoral scan along with a cone beam and incorporate them together. Already oral surgeons in Atlanta, Georgia, in the US, they're incorporating an intraoral scan and the cone beam, and they're coming up with a 3-dimensional form to make a surgical stent for surgical cases. So it's not going to be far behind before we start using it with aligners as well. So it is here. Once we know the length of the root, once we know the height of the bone, the software is going to have the algorithm to calculate exactly how much force is needed. So it's going to be even more custom made once we come to that stage. So it is here to stay. It is going to get better. Braces are not going to disappear, just like headgears. They didn't completely disappear. They're still here, but eventually with every generation, they're going to be less and less. And I think braces are going to be the same as well. So plastics do provide, especially their custom-made plastic, they do provide enough force. They're a lot more aesthetics. They cause a lot less decay. So regardless of the brand, I think the future of orthodontics is aligner therapy. And when you incorporate full treatment, when you incorporate implants and crowns and everything along with it, it's a lot easier to work with aligners than it is to work with braces. So it is here to stay. Learn from it, push it. At the end of the day, do what's best for your patients. I don't want to be philosophical. Do what's for your best for your patient and not what's best for you. Keep the patient in mind, and this will only get better with time.
Excellent, son. Thank you. Thank you.
Thank
And
you, guys.
I have to say sorry for, we have some questions, still have some questions, and we cannot answer all questions because we have time, but for sure, I'll
I'll
do
come
another
back
invite.
again.
I
I'll
invite
come back
Son
again.
again. For sure, I'm gonna do it, and it'll be a pleasure to have you here and get more questions and help us in our doubts.
Listen, I'm happy. I'll come back on. We'll do another session like this. And as soon as Corona is over, I want to go over and I want to have, I want to for sure have Brazilian steak when I go there, right? So if you promise me that, I'll go back to Brazil.
Yeah, and the point is, Sam Dyer told me earlier that they haven't started the vaccination over there. So in Brazil already started the for dentists and physicians, and so I'm suggesting you get a plan, come here, we get a vaccine in you.
I like that.
Okay, thank you.
Thank you.
Thank you, everyone. Thank you, everyone, for watching, asking questions, to join us. And thank you very much, Elaine, and for your smile. And thank you, Danny, for being here with us. And it's a pleasure to, and have to say thank you for everybody to help us in Dental Press interview.
Thank you.
Thank you
Obrigado.
very much. It's an honor for me. Thank you.
Ciao, guys. Thank you. Have a
you,
great day. Thank you, guys. Tchau, tchau.
Bye, bye. Thank you. Bye, bye. Obrigada, gente. Boa noite.